Hello. How y'all doing tonight?
We're doing all right. How are you?
I'm doing well, thank you. Jamie, have I had you in a different course before?
A while ago when I first started with this, I think you did a presentation or something, and I was on it a little bit. It might have been the new student thing. Who knows, girlfriend?
Yeah, maybe so. I remember. Nice having you
You
again.
you remember this lovely accent? Is that what you trying to tell me, Katina?
I'm not even going there. Don't start.
Don't
See?
even go. That's okay.
Look, see?
Girl,
Don't.
I traveled as a surgical tech. I was one for 25 years, and the last 11 was a lot of it was spent up north and out here in the west. Yeah, I'm all right with it. I had a neurosurgeon one time that wanted me to make the circulator mad because he'd want me to talk.
Well, I'm a Southern girl myself, so hey, we have a lot in common, right? Southern
There you
girl.
go.
Hey, yep. Well, thank you all for joining our session tonight. As you all know, these sessions are only 30 minutes, and I only lecture for about 25 minutes so that I can transition in between this lecture and the next lecture. But before I get started, does anyone have questions about the homework assignments or have any type of questions that they need assistance with? Because not only do we lecture, but we also want to hear your voice. We want you to know that we're here to support you to help you be successful in the course. So if there's anything that we could do to support you or answer any questions, just let me know. Okay? If you don't have
I
anything,
I have a question.
sure.
I'm sorry. I am in this course, but I don't think you're my instructor. Is the curriculum the same?
Yeah, actually, I'm not even teaching this course this term, but the curriculum is the same in every course.
Okay. Thank you.
Yes. All right, we'll go ahead and jump in and look at chapter 6. We'll cover some content here. If you have questions or comments, please feel free to join in. Okay. So as you all know, the looking at the content for this week, we're looking at chapter 6 for your readings. And so when we look here, we're looking at the topic is coming in the uncertainty in healthcare. So as you all know, healthcare is continuously evolving. We're getting exposed to new technology. We're getting new diagnoses. There's tons of research, observations, studies, introduction of new procedures and medicine. So, with the adoption and of all of the new diseases, treatments, and all of that, we have to look at the efficacy of the treatments, right? So
Yeah.
they say the special economic problem of medical care can be explained by the adaptation to uncertainty in the incidence of disease and in the efficacy of treatment. That's Arrow in 1963. Well, that still is true today. As we look at the way healthcare is going, technology, diagnosis, and treatment, it's always uncertain what we would have next. At this stage in our life, we never thought we would have dealt with COVID-19, and it's still relevant today. We don't hear as much about it because now they have treatment protocol, but that was an epidemic. So that's an example of the uncertainty of healthcare and then how much it cost us, right? When we look at this course from a financial perspective, institutions and organizations are still struggling today from the aftermath of COVID-19. Having to bring in nursing staff, having to bring in all of those travel nurses and paying extra, and that wasn't budgeted for. The organizations were given FEMA loans and those sorts of things to help them carry that bandwidth. The rapid introduction of the medication and the clinical studies. So when you look at, how these type of diagnosis and treatment impact us, there still lies a lot of uncertainty there. And then how does it impact, the healthcare stream? Some of the medications are not covered by health insurance. We didn't even know how to bill as an organization, how to bill for treatment of COVID-19 when it first came out. Normally, with the billing piece, you have 2 years to have a code introduced and to determine if it's going to be um, a viable code. Well, we were learning, it was trial and error. You was, baptism by fire when it came to the treatment protocols, how you're going to code the COVID-19 and all of the treatment methodology surrounding it. So, what was the risk of the medication, the medical practices? We had to figure all of that out. So that was a lot of uncertainty there. When we look in the United States here, we had to identify workarounds. There was redundancy. There was contradiction. So think about it. When patients they had to create rooms or spaces to put the COVID patients. We had patients in the hallway. That's traditionally against our HIPAA guidelines. The hospitals were busting at the seams. Policies had to be recreated or implemented, and they were ad hoc. So you had to make those rapid decisions. So we were working in disaster mode, okay? But then you still had to treat your regular patients. And some of that warranted uh, surgery schedules to be modified. So if it was an elective surgery, those had to be placed on hold. Some of the stakeholders that had like diabetes and hypertension, they were afraid to go into the hospitals because um, they were higher risk at contracting that virus. So these are some of the things that we face, right? And then financially, how does that impact us, right? So because the United States lacked a single national healthcare payment system, how the money is paid to the providers of healthcare has become very, very complicated. Um, we're not like in the Canadian market. They have one type of health care in Canada. Well, here we have private payers, we have governmental payers, we have our third party payers. So we have a mix. So that does bring some complexity. We have our Medicares, we have our Medicaids, we have TRICARE. So we have a mixed type of reimbursement methodology. So as staff members, you have to learn the various guidelines. What are the billing guidelines? How are we going to get reimbursed for these treatment and services? So these are some of the complexities that are brought into healthcare when we look at it from a financial perspective. Does anyone have any questions or comments they'd like to add at this time? So when we look at, how do we get support? What are the governing bodies? We have the National Health Expenditure Accounts. They provide the official estimates of healthcare spending in the United States. It measures the healthcare consumption and the healthcare investment. The benefits of it is the comprehensive, right? It includes all major components of healthcare, of the healthcare system in a unified way. So this is the benefit. They can measure what the expenditures are, how much revenue is going out versus how much revenue is coming in, what procedures are being used the most in some organizations. If you currently work in a hospital setting, you will know from time to time they look at their CDM. That's the repository with all of the codes and all of the procedures, and identify which procedures, if they are very expensive and they're not using them and it costs them a lot of money to maintain those, they may stop offering various procedures or treatment plans in certain healthcare organizations because the utilization, it costs them more to maintain the ability to offer that than it does if they get back in reimbursement. So it has to, the goal is to maintain and keep people healthy, but it also has to make financial sense for organizations to run. We can't run the doors without any revenue. So if it's costing us more to have that procedure or a practice in place, it may need to be mitigated.
Katrina, does that count for, like, I know a couple of places I work, one of them they'll try to be like a level one or level two trauma center. Doesn't that affect it? I know I have worked places where they worked to get the level one trauma, but then they didn't get enough, for lack of a better word, business in, so they went back to a level two. Does that affect
Exactly.
what they charge on the codings? Okay.
Yeah, it does because they have to get enough patients um in that category to ensure that they're making revenue. If not, it's costing them revenue to offer that service line. So if it costs them more money to um run that service line, they may not be able to offer it.
Like, I know they had the reason that one of the places that I worked at, and I don't think it was here. I don't think it was in South Carolina. I want to say Pennsylvania. They to be able to keep the level one status, they had to have a neurologist on call 24 hours. And I think that was the mitigating factor about the cost. I'm just now getting into the cost, and I was on the hands-on end for the rest of it, but that would be part of it, wouldn't it? What his salary or whatever they had to do to keep a urologist there.
Yes, it's too expensive.
Okay.
Yes.
Okay. Okay.
That could very well be it in some cases, and they don't have enough patients come in, or
Yeah.
they have to keep a cardiologist, or even sometimes it depends on where the market is. They cannot find physicians to
Yeah.
help them meet the clinical criteria they need to offer those services. I worked in the East Texas market, and we
Yeah.
had a hard time um, getting an oncologist,
Oh, okay.
right?
Okay. Yeah,
So
I
they
got
had
you. Yeah.
yeah. And so they had to change their scope of practice because they couldn't keep an oncologist on board there. And so they had contracts with like Sound Physician and all of these other cardiologists. They had a good contract with the Heart Institute of East Texas. So they had that, but they couldn't keep that oncologist on. And so
Yeah.
that was part of their whole scope to keep them at a certain level. Um, and then they end up having to sell off like their rehab unit because
Yeah.
they couldn't maintain it. So yes, it
All right.
was costing them more money to run that wing than they were
Yeah.
making.
All right.
Hmm. Good point.
Hmm.
Any more
So I
questions or
have a question.
comments? Yeah,
I do
go
have a
ahead.
question pertaining to the level one trauma status. So let's suppose they are the only resource to the community, and the next resource would be to airlift somewhere else. Would that play a factor in whether they keep their level one status or not?
So it depends on what the criteria is. I mean, we know what the
Yeah, they
criteria
do.
is, right? But it depends on if they can meet that status. If they can't, what they're going to do is get the patient stable and transfer them to where they need to go.
And then don't the hospital, the way I understand it, and like I say, Katrina, I told you I'm just getting into the money side. I think the hospital that does the transfer, don't they shoulder the burden of paying for the transportation?
The level one facility, yes.
Yeah, like saying they didn't have it and they couldn't meet it, and they had to. I know in some places they passed that. In Spartanburg, they used to do it. They called it patient dumping, and they passed that law that you have to, if you can't take care of them or it's not a critical need, you transfer them to another hospital. I just wonder if the place having it, if that comes in for part of their financial budget. You know what I mean? Talking about coding and being able to get the money and stuff, because it's a
Well,
tricky thing. Yeah,
well,
I've
what
heard surgeons
happens?
talk about it. Yeah.
What happens is they do share the cost, but
Okay.
so just say like they came to a facility in East Texas and we couldn't treat that patient, right? But we
Like
got the
labor and
patient.
delivery. I know some of labor and delivery, if they don't have what is it? A neonatal
NICU.
yeah,
NICU.
that
Yeah.
can treat the baby. Yeah,
That
they
level
can't, and
one or
they take
level
it.
two.
Yeah,
They
they'll transfer them out. I think it was in Illinois where that happened. They'll
Yep,
trans them out. So both places, that
get
would be
paid.
a bill for both places that would come out of their budget.
Yeah. Yeah, you get
Okay,
both places
got
get paid, but when they transfer to the level one trauma center, quite naturally,
yeah,
they're going to get the larger revenue because
yeah.
this facility A was just maintenance. It's just like we
Lord,
have to
girl.
get the patient stable, we stabilize them, and then we
Yeah,
move them.
yeah,
So, and even in some places where they do not have, just say, a helipad,
yeah,
to because they're not technically a trauma center,
yeah,
then they find a way to land them in the parking lot. So they'll land the helicopter in the parking lot and
yeah,
uplift that patient to get them out. So they do find ways.
So
We have seen them shut down 59 and let them land on the grass and everything
yeah.
in front of the hospital, and then they have to
Lord,
bag the
girl.
patient and get the patient to where they need to be to get them transported.
so
That's the
I
trip.
work
I
in
do all that financing for trip. Yeah. Sorry,
I
go
work
ahead.
in Illinois, and I've seen them actually airlift and land on in the parking lot, like on concrete.
So have I. I've seen them get as creative as land in the middle of, they had to shut the highway down and use the highway to get them to land because there was a small facility and they could not use the parking lot because it was full. So the closest thing was to shut that
Man,
highway down, and
yeah,
they had to bag that patient until they get the patient, on the
yeah,
helicopter and
yeah.
take them on out of there.
All right. Well, that's some financing, buddy.
Yeah, and so that cost for that, the air, the
Okay. Yeah.
helicopter, everything. So yeah, you'll get a chance to see some things, and learning this. I was in healthcare since I was 14. So before I
Yeah.
started teaching, but it's good to get that hands-on experience because then you learn. And
Yeah, I
me,
already got that. That's the money part. The only thing I ever got a chance besides like doing surgery and stuff like that was helping with the charting and stuff. A little bit. My daughter-in-law does the finance, and she likes works with the billing service and stuff, and she's got a head for that. And I'm just hoping I'm going to be able to do it. But it's way more complicated than I realized it was.
yep. And a lot of things that people don't think about right now is with the billing piece. So the new rule, I'm not sure if y'all heard of it. It's called surprise billing. It's not really new anymore. It's been out maybe about 2 years. So you know how before we would get those EOBs or we would get to the hospital and they'll say, "Oh, you have this large copay. This is how much your out of
Yes,
pocket is." So it's
yes,
called surprise billing that patients can no longer be surprised. We have to, as organizations, you have to notify them within a certain time period, give them
good.
the option
Yeah,
to pay. If
yeah.
they're indigent, everyone has to be given the same type of communication so that they're no longer surprised. When I used to work at the University of New Mexico hospitals, that's when that rule came out. So it's maybe about 2.5 years ago now.
Okay.
Um, and so this is like this whole healthcare financing, um,
I'm sorry,
administration.
it went into effect January 1st of 2022.
See,
The no
2 years.
surprise rule. The
Yeah.
no surprise.
Well,
Yeah.
I
So
wondered about that, and the reason I was asking, and I'm glad you told me that they're wanting me, and that's the reason I'm not still running around the OR. I'm trying to get something going that I could do from the house since I do have medical knowledge, experience, or whatever. And they had informed me they wanted to do a heart cath on me because they trying to keep up. I've got the weirdo anomalous coronary artery where my artery runs up the back of my heart instead of the front. Anyway, when I got started to do it, I got a phone call from my insurance company, which is Aetna, with the Medicare Advantage, letting me know that there was a $200 copay on it. Before they wouldn't have told me that, girl. I'd have went to the hospital and would have had to make arrangements, or they'd have billed me or whatever. So I'm kind of glad they do that. At least you know what's going on now.
exactly. So Tiffany, do you work in the billing office now? Since you know about the surprise billing, a lot of people don't even know about it.
Uh
So
uh
I I'm currently employed by Northwell. We just had like a boot camp recently that just told us all about this. I work as like the front desk support where we run insurance, take payments, all that good stuff. So this is something we needed to know.
Exactly. So what type of policy changes are y'all gonna have to implement within your organization?
So within our organization, we do something called eCare Next, and within eCare Next, it verifies their insurance first. And if there is no insurance first to verify, we create something called good faith estimate and send it out to them a week or two prior to their appointment. On top of sending it out, we email it and call them to let them know.
Mm.
Exactly. And you have to have all of that documentation. And before, with this surprise billing, there was a time when you're trying to identify stakeholders as being indigent or not having the ability to pay. You could ask them for their tax statements. You could ask them for bank statements. You can ask them for check stubs. Now you can only ask them for one thing, one piece of documentation. And
Ooh.
yes, because so they would ask for income tax, they would ask for check stubs and bank statements. You can no longer ask for all three. So those are some of the different rules that came into place, um, with all of these regulatory requirements and changes. Thank you for chiming in. That's some good information.
Yeah, it
Any,
is. I wondered about that. Yeah.
yeah.
No problem.
So some of our sources of the healthcare financing, as we are running close to time, I'll just say, here are some highlights here that you can see various um, parties that are in place to help ensure that the reimbursement methodologies and infrastructure are put in place to ensure that, everyone's treated the same. So that's the structure, regardless if you have you know, a Blue Cross Blue Shield or if you are on Medicaid, we should all be treated the same
Yeah.
and given the same quality of health care, regardless of where the funding sources are coming from. And so that's one of the good things about the way the healthcare system is designed. So any more questions or comments, any homework questions before I allow you all to
I do
jump
have a
off?
question.
Okay.
I do have a question. What about the uninsured?
Um, Uninsured. So it depends on each patient, right? Because some people can come in and they can have Medicare. Let's just say this. And they don't qualify for Medicaid. But if they're a financially indigent patient, they may, based on their finances, qualify to become a Medi patient. So you do have caseworkers and you have financial counselors in house that they go to these patients on a one-to-one basis. And if there is an opportunity to get them qualified for a Medi patient, they can do that. You can have some patients that have a primary and secondary insurance, and that still may not be enough, like you say, underinsured, and they may qualify for Medicare or Medicaid based on their clinical diagnosis and the if it's going to be a permanent disability. So there are additional resources available, and that's why they have to work with those financial counselors to help them, bridge the gap or give them the best resources for their situation on a one-to-one basis.
Thank you.
Yeah, great question. Right. If we don't have any other questions, I want to say thank you all for joining this session. I love the interaction, and I'll see you next time. Have a good night.
Thank you. We'll see you, Katina. Thank you.
All right, great. Have a good
Thank
night.
you.
Thank you. Bye-bye.